I think we're ready and we're all live. And I'd like to welcome everyone tonight to this in our ongoing series of medical discussion panels that we have. Thanks to the kind auspices of Ravi Shakamuri and Star Hospice. My name is Pat Canty, and I'm the publisher of the Odessa American. And again, it's my pleasure to be here to kind of help moderate this panel. Tonight, we're just coming off of a three-part series on diabetes, and we're talking about the kinds of issues and medical issues that face so many of us. And our topic tonight deals with smoking cessation and chronic obstructive pulmonary disease, better known as COPD. It seems to be getting more and more, unfortunately, more and more common in this country and around the world. Joining me tonight to help with this discussion, we have three wonderful local physicians. Want to introduce each of them tonight. First, we have Dr. P.K. Patel, and then we have Dr. Ajaya Kodi, and then Dr. Amaranth Ghanta. And what I'd like to do is start with you, Dr. Patel. If you could tell us a little bit about yourself.
Hi, I'm P.K. Patel. Would like to thank Ravi for arranging this or hosting this event, especially for young folks in Permian Basin, where this is something really nice of him to arrange so that we can make more aware or bring the awareness for, especially for the young kids, to kind of know what's ahead in life and how to handle at least some of those hobbies. And I've been in practice in Midland for last 24 years. I've been practicing internal medicine and pulmonary diseases. And thank you for inviting me.
Thank you so much. Dr. Kodi, tell us something about you.
Yeah, thank you for having us here. We thank Ravi and also Pat moderating this. This is a common problem. So we are happy to participate in it. We're going to talk about smoking cessation and also a little bit COPD. And Dr. Ghanta has worked very hard to collect a nice group of slides, which will be helpful to everyone, the people in profession as well as lay people.
Wonderful. I watched it, but I couldn't believe it.
Yeah, thank you. I'm here since 1992 in practice, and we enjoyed staying in this town, Midland and Odessa. So especially the weather, although today,
not today.
Yeah,
it's supposed to be spring.
Looking forward to
Thank you so much, Dr. Ghanta. Tell us something about you.
Yes, my name is Dr. Amarnath Ghanta. I am trained in internal medicine, pulmonary critical care, and sleep medicine. I am actually a transplanted Odessan. After I obtained my visa in New York City, I came straight to Odessa because of my family and went out to do my training and came back to practice, and I'm here for the last 31 years.
So all three of you qualify as veterans of native veterans of West Texas.
Yeah.
Well, so let's talk about this tonight. I guess to start off, let's talk about the habit of smoking. And obviously it's something that people get hooked on, and it's easy to get hooked on. And you're going to kind of walk us through some of these issues, and then kind of where that leads some people who've been doing too much of it for too long. Dr. Ghanta, we have some slides to kind of lead us through this. Could you tell us more about, let's start off with some of the grim facts about smoking and how dangerous it is to get addicted to it, and just how widespread it is, and how hard it is to quit.
Yeah. Smoking is, an important and unfortunately a problem. A lot of times people may not realize, looking at the family members smoking and they're not getting any kind of medical problems or trouble, they think they could, get away from the evils of smoking. That is one thing, unfortunately, people do not pay attention. I'm going to show a few slides, 2 or 3 slides, and basically that will highlight what kind of impact that it is going to have as a society, both economic impact as well as health related impact on the society. Look at the slide 2. Okay, if you look at that slide, there are total smokers of 34.2 million in the United States. Men are 15.6% and women are 12.8%. So if you look at the statistics, each day, 2,000 people younger than 18 years light their first cigarette. Each day, 300 people younger than 18 years become daily smokers. Then if you look at why people, quit, let's pay the attention to the slide 5. So when you start smoking, what does it cause as the economic impact to the United States society and healthcare wise, what does it do? The slide, it says here, worldwide, there are 7 million deaths related to tobacco use. In US, 480,000 deaths related to tobacco. That translates to daily 1,300 deaths related to tobacco. And look at another slide, 6. So the economic cost to the US society, these are mind-boggling numbers. The total cost is 300 billion, and medical care related to take care of these patients in our healthcare system is $170 billion.
So the 300 billion is more like the loss of productivity.
Exactly.
Yes, work days. Yeah.
Yeah, loss of work days, things like that. And the other thing is, do we, as a society, are we doing enough to curb this smoking use? Let's look at a couple of slides. Slide number 7.
Wait for it. There you go.
Okay. If you look at tobacco industry, how much are they going to spend on the advertisement? Look at that number. Per year, $9+ billion is spent on the advertisement. That would translate to 25 million per day. By the time we finish our talk, tobacco industry will spend $1 million in the advertisement. And
Dr.
okay, go ahead.
Yeah, sorry. So I think, as you said, the mainly it's like they're saying 95% of smokers start before age 21. So that already sum up with your statistics about how many millions of people smoke and all that, and then overall worldwide number is going down of the smokers. But I think, as you said, in America, they still not, or we are not doing enough to curb it. And as you said, perhaps they need to work more on spending enough money for people awareness.
That's
Yeah,
correct.
that's a good point. Of course, the advertising, the industry, they basically outlawed advertising on television and years ago and the like, with the cigarette companies. I remember growing up, it was not the Marlboro Man and these commercials. You don't see that anymore. But what this slide shows is the industry still does market. They spend tremendous amounts of money to market. So
I think so. Yeah, I think so. Quite a bit of thing. But if you look at the next slide, how much are we doing, to protect the public from that? 8. And you look at that money the government is collecting in the form of taxes. Money collected is 27.2 billion, and the money spent on helping the people to avoid smoking and their evils is only 740 million. That would translate to 2.8% of the money collected is spent to protect the public.
That's pretty disappointing, actually. I mean, it's almost kind of like the government went after the industry to try to do something about it. And with the money they're collecting, they're not really doing anything about it.
That's right. That's right.
Yeah, Pat, there is another point in the slide from the secondhand smoke, 41,000 people. That's a lot. That's a big
That's a lot of
number. We don't realize, somebody is smoking and we are within the vicinity for them. So that's also a big number of how many people are affected.
And you would think that the number would be lower than that. Because I remember living in California when they first started outlawing smoking in bars and restaurants and things. And I remember at the time it seemed radical because everyone just didn't think much about it. But now it's everywhere that you can't smoke in bars, you can't smoke in restaurants and some of these public places. But yet the number of secondhand smoke deaths is still pretty alarming.
Yes, it is.
So let's see. You're talking about the advertising here because I know you had it in another slide about how basically they well, go ahead. Let's talk about this. Who can get addicted to tobacco? Because obviously it's starting. And Dr. Patel, you mentioned this, kind of alluded to this. It's the younger populations. They get hooked on it first, and then they grow into it. Correct?
Yeah. And that makes it difficult for them to quit. The younger age they start with, and then it becomes really hard for them to try to quit later on in life. So the younger they start, it makes it perhaps harder simply because of the nicotine dependence they end up with, and they need more and more cigarette to take care of that nicotine high they usually get, because the brain just kind of handles it initially once it hits it, and then eventually people develop tolerance to that nicotine high they get with the amount they smoke, and they keep smoking more and more to get the same amount of high, and that just makes it hard for them to quit, and they even end up smoking, started with 1 or 2 or 5 cigarettes and end up having 1 or 2 packs a day.
And then Dr. Ghanta, that's a good point. So I'm a teenager, and there you go. That's how teenagers are getting hooked right there. Yeah. And say more about this slide here, because there's some interesting things I think that are in that.
Yeah, e-cigarettes. Okay, if you look at the slide, there is they are very, very popular with teenagers, and as you can see, their usage is almost like 19.6%, the highest compared to other regular cigarettes, etc. before. So it's easily accessible, and sometimes people even can use it in the classrooms because it's not very difficult to carry into the room, and nobody is going to even notice it. Mm-hmm. So these are unfortunately some of the things that are propagating this habit.
So let's talk about e-cigarettes for a moment, because you hear a lot of these young people, they do it and they say, well, I'm not going to get lung cancer from this. It's not like smoking cigarettes. They almost see it as a safe alternative, but it really isn't, is it?
It is not.
Why is that?
All the chemicals that are there in the cigarette smoke are also there in the e-cigarettes. They are not, and the nicotine is also the same chemical that you have in the cigarettes. So the nicotine will have all the effects on the body, like increased risk of heart attack and all the other evils. So e-cigarettes is not safer at all, contrary to what many people think.
Okay, and then for the young teenager that says, yeah, but it's not that addictive, I can quit. Say more about why they're wrong on that.
Okay, I have a slide on that, basically slide number 12. Okay, let's talk about here, okay? Go back one slide. And why the people who use these cigarettes, and we come across a lot of times, in the medical offices or in some other offices where the employees, take a break and go out. So the funny thing about nicotine is it reaches the brain within seconds after the puff. And as you can see, some of the smokers, the first puff they take, if you watch them, they feel relaxed and relieved and happy. Okay. And the effects will start to wear off within few minutes.
Mm-hmm.
Okay. So unfortunately, it is not like a long-acting medication in the medical world. It is not. I wish it is. So it is not. So then immediately, the person, based on their addiction, level of addiction, some people could go on for 3 or 4 hours, 5 or 6 hours. Some people cannot. They need the next puff, an hour, minute, 2 or 3 hours, whatever that duration is. And people who are, extremely addicted, and they look for the puff every hour or every half an hour. And then the other thing is, a lot of people don't realize, as you said, nicotine as cigarette, not a big deal. I can quit anytime. And it is not, I don't smoke every day, etc., etc. But if you look at the addiction potential, it is as addictive as heroin and cocaine. When you use say the word heroin and cocaine, drug, hardcore drug addiction, but you wouldn't think the tobacco is as addictive. But the fact is, it is as addictive as heroin and cocaine.
I guess the difference is heroin and cocaine, you could overdose and die just like that. Whereas I guess through nicotine, it's a potentially slow death addiction that leads to.
Yeah. You won't die immediately, but you will die over a period of 30 or 40 years. Yeah. Slowly. And, I have the next slide. Again, these are all socially acceptable things. Cigarette smoking. Yeah, my brother is a smoker. He smokes once in a while. My father is a drinker, or my friend is a drinker. He drinks alcohol. But look at the statistics there. If you are a smoker, and on the third thing, your success rate of quitting is 7.5%. That's not very high. And look at the middle one. If you are using excessive alcohol, your success rate is only 18%. But you may have a friend who is addicted to cocaine or opiates. His success rate is he's going to do much better. His success rate is almost like 40%. And
yeah, I think that's shocking. I mean, that's a shocking thing. I had no idea that the success rate for quitting smoking was so low, because you see a lot of advertisements that push different smoking cessation products, and they almost give this idea that no, you have a pretty good success rate when you're using our stuff, and the thought that it's harder to quit smoking than opiates and cocaine is just it's kind of depressing in a way, because if you're hooked on it, and there's obviously more people smoking and then hopefully than doing opiates and cocaine. Why is it so hard?
It's as we can see in the next slide, it's withdrawal symptoms are the ones that are bothered, that will bother the smokers when they try to. There are some other factors, but mainly when you stop or reduce the amount used, you will start having the withdrawal symptoms, and they happen, within few hours, minutes, and peak 2 or 3 days, and they last for a few days. But the smokers cannot take those symptoms. They cannot concentrate, they cannot enjoy, they cannot do what they want to do. Their thinking is not straight. They are bothered quite a bit, and that's why they want to keep going back to the cigarette again.
So how much time do y'all spend with, I guess, how time consuming is it with your practice with your patients? how much do you see that dealing with your patients and the frustrations they go through with trying to do smoking cessation? And
Okay.
tell me some more about some of your stories dealing
Yeah,
with your
this
patients.
is what I do in my practice. I'm a non-smoker, and I do admit initially when I came into practice, I probably was a little harsh towards smokers. Hey, listen, this is not good. You need to quit smoking, and it is going to do a lot of damage to your body, etc. But over the years, I noticed I have a lot of empathy because I know now how hard it is, like as hard as heroin and cocaine. And so my talk usually starts, hey, Mr. Smith, are you still smoking? I hope you are not. Then he will say, doctor, I'm trying hard. I cut back. And as a matter of fact, unfortunately, when they say I'm cutting back, they may not, or they cut back very little.
Mhm.
I try to encourage them. I say, you know what? I understand how hard it is, but I want you to understand, you are the one who could do it. Two, you need to keep trying. I have lots of people, quite a few people who are successful. You are not successful now, but you will be one day. Okay. So that is the thing smokers needs to realize. Okay. One, you have to try many times. When you fail, it doesn't mean that you should give up. Your success will be there one day. And some patients apparently tried 30 times or even more before they become, successful in quitting. And I still do, see patients that they are successful quitters. Actually, as a matter of fact, I saw one COPD patient today who quit a couple of years ago. And my conversation was, I can use the first name, Margaret, you told me that you quit smoking several months ago. Are you still, I hope you did not go back. No, doctor, I'm still not. And I said, good, that's good. I'm really proud of you. And you did really a big favor for yourself, etc. So that kind of encouragement and empathy is needed. And I have a lot of empathy. And I have a lot of patients, friends, and family members who are successful quitters.
Mhm.
I would like to add a couple of points there. What Dr. Ghanta mentioned, besides what he said, the kind of approach for those kind of difficult patients, or not so difficult, but as you mentioned, I try to each time I see them, every visit, I make sure that I ask them how's smoking going and how far they are in quitting, and at times you try to kind of find the opportunity to kind of tell them that, hey, okay, now you have a little more reflux problem. Stomach or your smoking does affect your acid, and you have more reflux problem if you are smoking. At times you try to tell them, hey, you have the cough congestion, it's going to get worse, and you get more bronchitis if you're still smoking. So it kind of use those indirect techniques in a way to kind of try to convince them or try to bring them back to the same issue of trying to say, okay, hey, you need to work on this, you need to quit. And slowly and steadily, some of them, they realize. And also I use other technique or kind of tell them or approach to say, okay, come up with a fixed date, quit date. You decide the quit date. If you already said, yes, I was smoking 4 packs a day or 3 packs a day, then they say, well, doc, I'm doing so good, I'm down to 1 pack. I used to smoke 4 packs. I say, hey, that's really, really good. But the 1 pack is still going to affect your lungs. So you need to still work on that and keep working. If you feel satisfied that you're down from 4 to 1, then that's it. You kind of feel good enough and you say you're doing good and you're not going to make further attempt to quit anymore.
Mhm.
So I would kind of tell them that, okay, no, if your birthday is coming after 3 months or your anniversary date is coming, you kind of tell them, hey, that would be the best gift to your wife or
Right.
your loved one. Just try to work on to see if you can quit by that date. So if I say, yeah, 1 pack has 20 cigarettes, I tell them, hey, just cut down by 5 cigarettes every month, and you'd be done in 4 months. So it's kind of it's certain different little the clue you kind of give them and keep encouraging to say, hey, yeah, keep working. You are doing good, and that's the best way you can quit. But if you have to have a fixed date, because I said you have to decide really you want to quit, not just okay, you're working on it. You may not be able to still quit even 2 years later. When I see you, you might still say the same thing. So I kind of push them for that, and indirectly or use at times these scare tactics in a way to say, you look,
Right.
you're going to have a little COPD. Now you're going to have more shortness of breath. You see the other patient in that room who came in with the oxygen. You picture yourself, you would probably be doing this 10 years down the road if you still continue to smoke. So that kind of gives them a little bit of thing to think about and be more motivated, because as Dr. Ghanta said, it's just they are not ready. They have a fear of quitting and fear of withdrawal symptoms. So then you kind of say, okay, hey, you're expected to have some withdrawal symptoms, but those symptoms, when you have the withdrawal, you have to see that as a good sign to say, okay, hey, you are really working. Your body is trying to tell you something. You are trying to get rid of this habit. And so you just deal with it. They get shaky, they get nervous, their concentration is down. And that's one of the reasons they right away want to reach for a cigarette, which kicks in less than a few seconds. And they feel like, oh boy, they are relieved from all that frustration and tension and anxiety and fear. And so you had to kind of tell them that, hey, it's okay to have some anxiety, whatever. You try to tell them, hey, you need some chill pill. I call it chill pill, to kind of tell them, okay, if you need something to calm your nerves, certainly we can use some anti-anxiety medicine at times to kind of say, okay, just let's use this to curb your habit and work on it. And so those little bit of different techniques, any whichever way possible, you try to kind of bring them back to say, okay, your smoking is what just bringing you all these other symptoms and other illnesses. And so then that way you kind of mentally prepare them, make them more motivated to kind of work on it.
Right.
As Dr. Ghanta said, we see patients at times who come up with the 30 years of smoking and develop the little nodule in the lung. And then lo and behold, it's a cancer. You remove their third of the lung. And they get scared and they say, okay, this is it. They stay quit for 6 months. And by 7th month, suddenly they reach for one cigarette. And before you realize, they're back to full pack of cigarettes. So that's one of those real worry that we say, okay, yeah, it's a real hard habit to quit. It's worse than cocaine and heroin in that regard. Yeah.
I knew someone once who smoked for years and they were able to quit. And it's crazy, but used to have the pack in the pocket, and he got rid of the pack and he just kept one cigarette in his pocket. And every day when he had the urge, he would take it out and he'd say, I'll smoke this tomorrow. And he'd put it back in. The next day he'd come and he'd pull it out. He'd say, I'll smoke this tomorrow. And he kept putting it off and putting it off. And after about a year or two, he's took the cigarette out. And for him, that worked. I'm sure he went through a lot of withdrawals, but so talk some about some of the, you said there's medications that you can take, to help with cessation or with quitting. What are some of the medications out there that tend to really be helpful?
I want to add, PK brought up some good points, Pat, if you don't mind, I'm going to add a couple of things there.
Absolutely.
Every physician or every one of us have our own way of dealing with that kind of problem, help the patient as much as we can. And some of the things that I do are, a lot of times patients come with their loved ones, husband, father, daughter. And as PK said, instead of putting them what their birthday is, I will ask them, what is your husband's birthday? Okay, and then I will say, yeah, it is coming up, May 12th. And I'll say, don't you want to give him a gift? Oh, of course I do. Okay, then why don't you do this? You quit smoking, and that's a gift for your husband. And then, they like that and, try to stick to and, fulfill that, wish. That is one thing. The other thing is, sometimes we talk, doctor, it's very hard. I tried. Trust me, I am really, really trying hard to quit. Then I would say, okay, then why don't we do this? Okay. How do you smoke? Yeah, I buy a cotton. Okay. Son, why don't you do this? Don't buy the cotton. Okay. Buy, maybe a pack with that particular patient. Okay. Then, you are not going to have a cotton. So if you run out of that pack, you have to go out and buy. Hopefully that will discourage. Okay. Then I might run into somebody who buys a pack. Then I say, you know what? Don't buy the pack. Okay. I want you to buy loose cigarette. Okay. 1 or 2 cigarettes or half a cigarette, things like that. And that will also, some patients give the feedback, those things to work, try to discourage them really to smoke, okay. So those are some of the, things we do. And then, I ask them also, listen, why are you, some people say, I'm not going to, I'm afraid of quit smoking. Then I would say, why? Why are you afraid of quit smoking? And some of the things are, they say, or, I'm afraid that I might gain weight.
Yeah.
I'm afraid that I may not be able to do my job, efficiently, because my mind is not going to be as sharp as with tobacco. And, all those things will come into picture. So if you look at one slide, why smokers are not going to try hard and be unsuccessful, and there are a couple of things, a few things there. Okay.
Yep.
The first one, as you can see, everybody is fearful that they are going to fail. I hardly come across people, I did come across, but very few people say, first try, just quit, not, weaning or going down and things like that. Yes, I have some patients who did that. That's it. One day they woke up and say, I'm quitting, I'm done. But not many people. Why? Because of the withdrawal symptoms. And weight gain is really a big factor, especially females. They are afraid if they quit, they are going to have weight gain.
Right.
And then we already talked, I already said a lot of them mention about mood changes, depression. And then some people, say, listen, I enjoy it. So that's why, I can't quit. And the last two things, unfortunately, are there from some of the physicians who don't appreciate how hard it is. And they could be, they could be harsh. And some of the family members. And in our exam rooms also, sometimes I have seen patients' families and say, doctor, you tell him, he is not listening to me, he quit. Then I usually tell, hey, listen, I understand, I want him to quit also. But at the same time, I want you to understand it is a very hardcore addiction and he needs support and we need to be compassionate. There is no question about it.
And I think that's an interesting point, because I think, unfortunately, smoking is one of those things that have been stigmatized, in that people used to say it's a bad habit, whereas it's more of an addiction than a bad habit. You started, but the addiction is what got you. And so I think a lot of people, though, they don't see it that way. They say, well, it's more like it's a lot like any type of substance abuse. It's an addiction. It's a disease. It's not the sign that you're a bad person or it's a character flaw. But I think a lot of people have associated it with, well, it's a character flaw. Back in the 50s and 40s, it was a real popular thing to do. And so but I think that's where that underscores your point about, well, he's not doing what he's supposed to do. They need to understand that it's not that easy. And go ahead.
Sorry, go ahead.
No, go ahead, doctor.
So it's the same as you said with the being around the smoker, as you mentioned. If the husband and wife both smokes, then that's one of the problem there. The husband is ready to quit, but then wife is not willing or not ready. Then we know, as Dr. Ghanta said, you have to make sure that both are willing to do it together. Because if a husband is going to try, it's not going to work if he smells it a little bit on the wife, and there is no way he can quit unless she is willing to do it together. Yeah. With him, and so that kind of makes it hard as when they are ready to quit, but then lack of support, as you said, it's the same thing in a way. At times you need some coaching or somebody around to kind of encourage you to say, hey, you smoke only 3 cigarettes today, it's half day is over, and you're doing good, keep it up. So those kind of things really help. If they have one person in the house or a few or any other relatives who watches there and make sure that yes, he gets cranky or whatever, then he understands that okay, this is just because he's trying hard to quit. Then they try to be more sympathetic with him and try to kind of encourage him and say, yes, you're doing good, keep it up. So that kind of support system they definitely need anybody who's willing to quit.
Well, and also think about it. If one's quitting but the other one's not, the one who's quitting is probably being exposed to secondhand smoke.
Yes.
And
Yes,
actually,
totally.
we just had somebody send in a question saying, how harmful, we talk about it is harmful, but how harmful is secondhand smoke to a non-smoker? And how does secondhand smoke impact the children in a family?
Yeah, we showed the numbers earlier, Pat, the 41,000 people die each year. That's a big number. That's a very big number we didn't appreciate before. Now we do. And if the husband and wife both are smokers, I look at the wife, okay, you're smoking, you're damaging your lung, but also you're damaging your husband's lung. And look at the husband, you're smoking, you're damaging your lung, but in addition, you're damaging your spouse's lung. So sometimes that point gets
you have children too. If you have children in the family,
and they'll be damaging their lungs too.
Pat, you're talking about the children. If especially for the young folks, if they have the infant in the house and parents are the smoker or one of them is a smoker, that person is increasing the risk of the infant having the sudden infant death syndrome from their smoking. So if you talk about secondhand smoke, real ill effect, that's something really, it's something they really need to keep in mind. Also, they say the first cigarette, any smoker, a pregnant woman, before she gets pregnant, if she starts smoking, that she has a very high chances of having a miscarriage, having the underdeveloped kid, the baby with all the congenital abnormalities also. So secondhand smoke, it's really important in that regard too. They are nowadays talking about even third-hand smoking, not second-hand smoke, where they are coining that term as third-hand smoke, where you already have smoking, you have smoked, and you're coming home, you take off your clothes, but you're smoking in your own bedroom. There are residue of all these tar and nicotine and all the other chemicals from the smoking, which are the residuals on the walls and on the clothes. With the exposure or those chemicals getting in contact with nitrous oxide creates the nitrosamines, they call it. So basically, they are still up in the air, and that you inhale, it's still not healthy for the lungs. So they are even talking about smoking, not just smoking outside the house, or you just say you go out and smoke. Yes, you are at least cutting down some risk of secondhand smoke, but then when you come home, that with in your own breath and your clothes still have that issue with the exposure for the your loved ones in a way, which indirectly affects you, not on a day or 2 or 3. We talk about the long-term effect there. So those are the things that really another thing is if the parents are the smoker, the kids are at high risk of middle ear infection, asthma risk, and all that goes up with the kids. So we know when we talk about the young adults nowadays, they say, yeah, we used to sit in the back of the car, and Dad used to smoke, and we had to roll down the window, and boy, Dad was getting mad, and but that we could not breathe, but we could not complain because boy, he would get mad, and so it just.
Right.
But they say the middle ear infection, frequent upper respiratory infection, and asthma. All these three things they need to really keep in mind that as a parent, if you are doing that, you're indirectly affecting your kids who are still growing, and that it really affects their health on the long run too.
Right. So let's talk about COPD because we're running close to almost an hour. But let's talk about COPD because let's say someone's been smoking for years, and then lo and behold.
Pat, if you don't mind, you brought up a question. Okay, what is it available medications and all that?
Okay. Yes.
Okay. In my opinion, people needs to understand smoking is, as we said, very injurious to the body, and then everybody needs to try to quit. Mm-hmm. And there is a lot of help available in the communities. In the communities, there are smoking cessation programs and helplines. A lot of things are available. So usually as a physician, we do the best we can, especially the pulmonary physicians do a good job of discouraging tobacco use and try to help the patient to achieve that goal with what we talked about, supporting them and try to give them clues and all that. Then as far as the other avenues or other helps are concerned, you have counseling. The counseling medical center used to have a counseling sessions. They could be individual if they have access to some of the psychiatry departments and all the psychologists available. They can sit on an individual basis, or they can give group sessions, or they can do telephone. Even some of the states are able to provide that kind of support. 2, nicotine replacement. Actually, several years ago, it used to be a prescription medicine. Not anymore. You have nicotine lozenges, you have patches are available over the counter. So basically, the goal here is a kind of like a controlled smoking or controlled infusion of nicotine into the body, slowly wean yourself, or try to avoid these sudden withdrawals. So let us say a smoker is there, okay? Then they quit and they are going to have this craving. You can put the patch or you can use the lozenge, whatever, and the symptoms are going to be less. And as per the slide, the withdrawal symptoms are not going to be there forever.
Right.
They're going to be there for a few days or for a few weeks for some patients. So if they bridge that period with something replacement, then they will be a successful quitters. So that type of nicotine replacement therapy. And at times, if you are with a physician on a prescription level, a physician can give some of the prescriptions medicines to help them quit.
Okay.
And unfortunately, there are side effects, and the quit rate is not very high.
Okay.
So those are all people, there are avenues or there are things are available in the community that they need to, and they need to discuss with their physicians and other healthcare workers.
Good deal. So let's talk about COPD. Let's say, obviously it's from what I see, it seems to be a growing problem. And I don't know if it's a growing problem or if it's just something that we know more about it, and therefore it's out there more because it's more easily diagnosed. Tell us more about COPD and kind of, what is it, what causes it, and treatments, things like that.
I mean, as is COPD, I don't know whether the incidence is, increasing or not. The smoking fortunately, as a whole, is coming down a little bit. But I think teenage smoking is, I read sometimes, it goes up, sometimes it goes down. I don't know what the latest thing. But as you said, you brought up the thing, more of awareness and testing modalities being available. I think, as a society, we are doing a better job. Hey, listen, you could get hurt with COPD affecting you and all that. I think those are the reasons that you might perceive that a lot of people are labeled as COPD, and maybe a little bit of more testing. And that's my opinion about the incidents and what you see. But you brought up the question of, what is COPD? What causes that? It boils down to all the substances in the not only nicotine, a lot of other noxious gases and substances are there in the tobacco smoke, and they cause the lung inflammation, and that inflammation will cause for the air movement. The lung, when you breathe in, the air goes in. When you breathe out, the air comes out. So there is obstruction to that movement in the air, and that is COPD in a simple sense. And what causes COPD? Commonest cause in the United States is tobacco use. But obviously, there are other causes. Somebody could have asthma, which is not very well controlled, years and years and years, and they could have it. Secondhand smoke could do that, even though they are not the active smokers. And it doesn't happen here. Dust, pollutants, environmental pollutants could do that. And back home, when I was growing up in India, they used the firewood and the smoke they used to inhale. And that used to be a big cause for COPD, even though people did not smoke. Females, Indian females, those days, very little smoking, but they used to, in the cooking, they used to use the firewood, right, and they used to inhale smoke, and it used to cause, COPD. So those are the, main causes of why, how it is, COPD is caused.
Okay. So, Dr. Kodi, is COPD similar to something you heard of turn of the century black lung? Is that a similar type of thing because of substances in the lung, and or is it dissimilar to black lung? It's more of the long-term effects of the irritant.
Yeah, physiologically, Pat, I feel it is similar. The black lung in some of the states like Kentucky, it's because of the coal inhalation, the pneumoconiosis, but physiologically, pretty much similar and treated similarly.
Okay, good point. So
another thing is we have to tell people who have, so not everybody who smokes gets COPD. The slide 23.
That's a good point, because I always associated with, well, you smoke, you get COPD, and the only people that get COPD are smokers. But that's not true.
They're not smokers, but as physicians and as a society, a person is smoking, there's no way for us to tell whether they'll develop COPD or not. The best way to prevent is to tell everybody who smokes to quit smoking.
So what percentage of smokers run the risk of COPD? I think y'all were talking about that earlier.
Yeah, about 15% of the smokers get COPD.
Okay. And
slide number 23.
23, yeah.
Okay. And so when you talk about the people that get COPD that are non-smokers, can you all talk more about what causes that? It's obviously an architectural, a developmental issue with the lungs. Is that correct? Or
they may be exposed to the other irritants, environmental irritants, pollutants, they may not be smokers of cigarettes, and they can get it too.
So what are the symptoms? I'm short of breath. Let's say somebody's like, well, I'm walking up the stairs, or I'm, and maybe I'm 50 pounds overweight, and I'm short of breath.
Yeah,
Do I immediately assume I have COPD, or someone comes to you like that? What are some of the symptoms to look for?
Yeah, one is of course the cough, what we call a chronic bronchitis. Then later on, they have trouble breathing in and exhaling out. So that at that point, they will be very short of breath.
26, it's all there in the slide 26.
So shortness of breath, chronic cough. You mean chronic cough, you mean coughing all the time?
Yeah, chronic cough with some sputum production.
Okay.
Trouble taking a deep breath, shortness of breath. And typically we used to call them either pink puffers or blue bloaters, but they always, and sometimes they're mixed type. So they are all related to the effects of the smoking. And when they're short of breath, you really have to see this, how they struggle to breathe. And
right.
That's one of the things we tell the patients, hey, you want to be like that. Then that sometimes drives the point. And when someone cannot breathe, that's the real suffering.
Now, I think Dr. Ghanta, you have an interesting slide here, a graph that shows that just because you don't have, it's one of those kind of maladies that by the time you develop some of these symptoms, or it's actually detected, it's already almost too late. You've already suffered significant damage, correct?
That is correct. Okay, if you go to slide 30. Okay, this is a very important slide. Actually, I spent quite a bit of time with my patients. And here, as you can see, the box at the bottom, 3 boxes, small boxes, death, disability, and breathlessness. So the top box, 1, 2, 3, fourth box, the top box is almost occupies about 2/3 of the thing, right, of the slide. So that 2/3 is actually the lung reserve. So here what happens is, if you look at the left side, the vertical line, and a patient is about 25 years old, and the lungs are in best shape and they are the strongest. They picked the habit, maybe 21, 22, and then they are smoking. 5 years went by, lung function has gone down a little, 2 or 3%. They are now 30, then they went to 35. They are now another 10% went down. So by the time they reach like 50, 55, they lost about the top box, like 2/3 of the lung function. They have another 1/3 left, right? At that time, they are doing something, whatever that is, going up on the roof or lifting something, patient's wife asks, then you are short of breath. Then you are going to say, patient is going to think, I'm out of shape and I'm older, so I'm not surprised. Then they come to the doctor, come to me or somebody else, and then we suspect, actually by our physical examination, unfortunately, we may not be able to suspect. I have been wrong before. Mm-hmm. And every one of us will be or could be. So you do the testing of the lung function test, and then you realize 2/3 of the lung function is gone. They have only 1/3 lung function left. So people get surprised. I did not think that I lost, that much of lung function, because you are cutting into your reserve. If you are short of breath 20 years earlier, you could have caught the disease 20 years earlier, but you wouldn't. The reason is you are cutting into the reserve, not the, actually lung function. The other thing is that important take home point on that thing is, after the red line, you see that dotted line, if a person quit at that junction of that dotted line and red line, instead of red line following the red line, that particular smoker will slow down the natural decline of the lung function. Because also people need to realize we are all losing lung function every year, a little bit. That is a natural progression, natural decline of the lung function. But as you can see, he slowed down quite a bit compared to a smoker who is a red line. And let us say, example, a junction or at the meeting point of red line and the right dotted line, a person quit, right? And then he came to the doctor 10 years after. What happened? Because of the natural decline of the lung function, he is already at the breathlessness. That is another surprising thing in our offices that we see. They come to us, my doctor told me I am 63 years old, and my doctor told me to see you because I'm short of breath. Then we do the history and we do the testing, and then I come back to say, I'm sorry to say that your lung is only working 35%. Doctor, are you serious? I quit smoking 20 years ago when I was 45, but now I'm 64. You are telling me that I lost 2/3 of the lung function. Okay. So the reason is, as a smoker, you lost almost like 20%, where the meeting point of the dotted line and the red line. And then the natural lung decline brought you down to 35%. So now you are having symptoms. If you never smoked at the age of 65, you would be on the green line. As you can see on the green line, you still have the reserve, right? So you are not going to be short of breath with a minor chores, lifting things or, climbing stairs, etc. So it is not, unfortunately, a lot of patients get surprised when they get tested. Again, the clue here is a physician cannot predict accurately whether you have COPD, and if you do, how much. Okay, so that is the reason why smokers or ex-smokers should bring it to their physician that they are active smokers or ex-smokers, and they would like to have the lung testing done, know what they have.
Right. Because I mean, COPD is a chronic disease. You live with it. You don't get cured from it. But I guess being able to diagnose it accurately, there are medications and things that could obviously increase your quality of life and possibly your length of life too, as long as you stop smoking and you follow the regimens. Correct?
That's correct.
Yeah, unfortunately, yeah, the medications, they help, but medications do not change their prognosis. Yes, it does improve the quality of life. It helps with their handling their daily chores and help them feel better. But unfortunately, the medications are just more for the symptomatic treatment. Certainly, you keep them on a maintenance medicine, which prevents them from having a further so-called exacerbation or flare-up of the disease. And that way, hopefully, it kind of helps keep them in a optimum shape of their lung function. And that way, indirectly, it helps them with their overall life expectancy. But none of the medications so far showed to improve the life expectancy except oxygen. So, and certainly nowadays we talk about pulmonary rehab, which is the best thing or better option for all those patients who have difficulty handling their daily routine. And unfortunately, as we were talking about before, government is not really helping much in that regards to have those pulmonary rehab places where Medicare patients can still go through those endurance training, the specific treatment or exercise programs designed for patients with a lung problem. And certainly it improves their endurance, improves their life expectancy, their quality of life in some life expectancy. But unfortunately, we are not able to have that kind of programs available all over US. And we are at least fortunate enough that Odessa has at least one there, which really helps out. We refer the patient there, and quite a few patients really have a good result. But again, they offer it up to 4 to 6 weeks, and beyond that, again, patients lose their own motivation to continue to do it at home. And certainly, certain exercise they cannot do that at home, but that's something really helps.
Good points. We are at the magic hour, 8 o'clock. And so unfortunately, we need to kind of wrap this up. What I'd like to do is kind of go around and just get some closing thoughts from each of you, starting with you, Dr. Patel.
Well, yeah, only thing I would say is prevention. As you said, Dr. Ghanta took a lot of time to explain that graph, what really helps you look at in a nutshell, how the disease progress and at what point you in life you end up having those symptoms. And out of shape is our usual complaint, but it's not out of shape. You are playing tennis, then you stop playing tennis because you can't handle it. Then you end up not doing the yard work, and then you have issues with even housework. And that's when suddenly you say, boy, I'm feeling short of breath. But that's too late by the time your 2/3 of the lung is already gone in a way. And that's because even if you had quit smoking 15 years ago, you are at the point where physical decline is still catching up with you at the time. So prevention is the main thing. The day you stop smoking, you prevent further damage to your lungs. So if you stop smoking at age 30, that's the best. You have a normal life after that. If you're doing it at age 50, that's going to still give you decent quality of life until 70 perhaps. But then if you are doing that after 60, perhaps you are not having much to look forward to thereafter once you have a severe COPD. So prevention would be the main thing. I would say we have to take enough time to make sure that catch them early on. So all the primary care and docs have to do breathing test, PFT, on anybody who's smoking more than 10 years period.
Good points. Dr. Kodi.
Yeah, I agree with everything Dr. PK and Dr. Ghanta said. One of the things I want to emphasize to every smoker is never say never, never too late to quit. Mm-hmm. That's number one. Number two, in some of the slides I did not bring, it was in my cell phone, it will cut short the life. People who smoke and develop COPD, it will cut short the life. Sometimes I want to tell the patient, do you want your life to be cut short, especially if they are 30 years, 40 years, 50 years old? And sometimes that point is driven into their brain. Do you want to cut short your life? Is that the reason you're smoking? Because you're enjoying? Sometimes that drives. On the average, some of the information I had, it will cut short life by about 10 years. That's a lot of time. You know, people who start young and keep smoking, their life is 10 years is taken from their life. So that's very important. So like PK said, prevention and understanding the disease. I know quitting tobacco is hard. A lot of support to the patient, support to the family, managing the withdrawal symptoms. There are some medications available. We know that quit rate is low, but that can be improved. You know, everything. You know, as a society also we have responsibility. Not too long ago in some of the states where I was practicing, the people were dependent on tobacco industry and tobacco crops. And as physicians, we were told by some of the hospital administration, be gentle, don't talk that harsh about against the tobacco. But I'm glad we came a long way from that point. So I think we are doing better. The job can be done even better as the time goes on. So I agree with my colleagues, and also thank you all for giving this opportunity.
Thank you, Dr. Kodi. And last but not least, Dr. Ghanta, your thoughts.
Tobacco addiction is a very serious addiction problem. Every smoker should consider quitting. As a physician, community need to give as much support as possible. and be sympathetic and empathetic. And tobacco, even though it doesn't kill you right away, it is going to kill you slowly, which is very uncomfortable and painful, as PK pointed out. As a society, it is our responsibility to provide both financial and other help for the smokers so that they are successful in quitting.
Emotional help, spiritual help, anything we can do.
That's a good point. Well, thank you, each of you. Thank you so much for taking the time to visit with us tonight. I thank you for taking the time to help us learn more about this, but more importantly, I thank you for dedicating your lives to helping patients in the Permian Basin. You help make life here better. So thank you for what you do. And with that, I'm going to turn it over to you, Ravi.
Thank you, Pat. I appreciate you moderating the conversation as always. And Dr. Ghanta, Dr. Kodi, and Dr. Patel. Dr. Anand Reddy had a question. Many of his patients complain about gaining weight if they do smoking cessation. Can you share a little bit of your thoughts on that topic, please? It's an important question that comes up. What are your thoughts on that?
Well, I think if I start that, most of the time I tell the patient, hey, if you gain 50 pounds and you carry that 50 pounds for 3 years, that's not going to hurt you. That's not going to kill you. But 3 years of smoking, further damage to the lung would not be reversible. So I tell them not to look at themselves in the mirror for a year, but to make sure that when they won't feel guilty or they say, oh, no, I have to smoke because I don't look good in the mirror. And so basically, I tell them that gaining weight, you can always work on it 2 years, 3 years later, once you are, or even at least after a year, after a year of quitting, once you feel that you're confident enough that you're not going to go back to smoke, that's when you start working systematically, slowly over your weight issue. But quitting smoking is way far more important than even gaining 20, 30, 40 pounds even and then deal with that over another 3-4 years, even or 5 years would not really affect your overall quality of life or your health.
Is the weight gain, is it a physiological reaction from stopping smoking? In other words, your body doesn't process the fats properly, or is it because you're kind of compensating as you withdraw from one addiction, and the reaction is perhaps to overeat?
Is it physical? It's physical and mental both. It's a hand and mouth ritual. You like to put something in the mouth because you're not holding cigarette. Other one is more craving part of it too, where you are already frustrated, you're going through withdrawal, then you look for something as the reward to kind of cut down your brain's craving for smoking, because you become more frustrated. And so that's just, it works in both ways with physical and mental craving both.
The smokers usually have higher metabolism, about 10%. So when they stop smoking, so the metabolism slowed down, so they tend to gain weight. One of the issues, peak at that point, is well taken, but sometimes I put them on Wellbutrin, which is one of the medications to quit smoking, and that blunts the weight gain sometimes, and it helps.
Also, patients share once they quit smoking that food tastes better. Because of smoking, it's not masks a lot of things, even though they enjoy the tobacco smoke and all that. Mm-hmm. Apparently, food smokes better, and they eat more.
Mm-hmm. Well, Dr. Patel, Dr. Ghanta, and Dr. Kodi, thank you very much. It's an important discussion. I hope to open up some more minds to this important topic. So thank you for volunteering your time and sharing your thoughts. And Pat, thank you very much for moderating this excellent conversation, sir.
Thank you. I really appreciate it.
Thank you.
Thank you, Pat. Everyone.
Thank you all.
Bye-bye, sir.
Bye.
Bye-bye.